So, so that's the sort of things that we might see on a patient as they progress through the different stages of shock. Okay. Now, we've already said that shock is because there's a problem with circulation. So if we think about how people can lose blood, so how can people lose blood from their body?
Internally and externally.
Yeah. And so what can we do about internal bleeding?
Go to hospital. Yeah.
Recognise it.
Yeah. And definitive care.
Yeah. Get more senior help and get them to somewhere where they can be treated. That's
blood on the floor plus four more. Blood on the floor plus four more.
So where are the 4 places?
Long bones.
Long bones. So thighs especially.
Abdomen.
Yeah.
Chest.
Abdomen, chest, and pelvis.
Pelvis.
Okay. So we'll talk about the pelvic binders as part of that, because that's where we're trying to control bleeding in the pelvis. What can we do for the chest? Recognise it.
Yeah.
Get them to somewhere where it can be sorted out. Abdomen. What can we do for that? Again, recognising it is really important. Yes, because if you don't recognise it, then
how do you recognise?
So you'll see bruising. You'll see bruising. It might be swollen, might be bruised, might be very painful. Okay. Long bones. How might you recognise that there's bleeding inside them?
Discoloration.
Discoloration. So bruising. What else?
It's probably broken.
It might be. Yeah, it might be broken. So you might see it. It looks out of shape. Yes. What else might you see on long bones with bleeding?
Swelling.
Swelling, yeah. So absolutely. So if there's a lot of blood in and around long bone, it will be swollen. If it's broken and it's bleeding, so it will be out of shape. And if there's a lot of blood that you can see on the skin, it will be bruised. Yeah. Okay. So it might be painful, it might not be. Okay. So those sort of things. What about external bleeding? How might we identify that?
See it.
Yeah.
Hopefully you'll see it, yes.
Yeah.
But where can we get external bleeding from?
Anywhere.
Anywhere, absolutely. But there's 3 real main ways that people can bleed externally.
Arterial, venous,
arteries,
and capillary.
Capillaries,
Yeah, absolutely. So if we think about, and it's quite important to recognise, and you can lose a lot of blood from all of those. It doesn't matter which one it is. So if we think about arterial bleeding, how might we identify that?
spurting.
Yeah. Yeah. So it's a high pressure system. So it will come spurting out.
Light. It's a light red, yeah.
It's a little bit brighter. You can't. It might not be so easy to tell, but it might be a bit redder rather than a more light red rather than dark red. Yeah. And what else?
Spurting, and usually when you come there is more of a color.
Think about what's causing it to spurt out. What's happened? It's the heart beating, isn't it? So it will be pulsatile, and it will match the pulse, won't it? What about capillary bleeding?
Usually very low, dark.
Very low pressure, very weak.
It's very low pressure, and it's more an oozing type because obviously it's very small blood vessels and it oozes out, right?
It should be a larger wound.
It might be a larger wound, yeah, and it might not be.
Serious for capillary.
So it could. What about if someone's on a blood thinner? They can have a graze and that can still bleed loads and loads and loads.
For a few days.
But it can bleed. So I'm saying so just because it's a small wound doesn't mean it doesn't bleed a lot. But it will just be more of an oozing type wound because of, as you say, it's small blood vessels, low pressure. Okay. What about venous bleeding?
More dripping, flowing.
It's more flowing, yes. So it's already a larger blood vessel than the capillary, so there's more volume there. But it's low pressure, so it will be flowing out rather than spurting out, rather than weeping out. Absolutely. Okay. It might look a little bit darker because again it's deoxygenated, but you might find it quite difficult to tell.
So on some blood thinners.
Yeah.
Is there less blood content?
There's the same amount of blood contents. It depends which blood thinner they're on as to why they're bleeding. But essentially, what blood thinners do is they stop the body from being able to clot. and clotting is the way the body keeps blood inside it.
And if I'm putting gas with the clotting agent, it won't help?
It might help. Again, it depends what blood thinner they're on. It depends where in the clotting pathway the blood thinners are acting as to what it might do.
The drugs to reverse it, so they get to hospital, they be able to give something to reverse that blood thinner they were on.
Yeah, some of them are reversible, some of them aren't reversible. But there's other things that can be done as well if you can't stop it. Worst comes to worst, the hospital is able to tie off the blood vessel that's causing the bleeding. Okay? And I remember looking after a patient who had a leukemia, I can't remember which leukemia, and they had a nosebleed that we weren't able to stop after 2 weeks, and eventually they went to, so after having a couple of blood transfusions for this nosebleed, we took them to theatre and we literally went in and we tied off their blood vessels in the nose that was causing the bleeding. Because that was the only way to stop the bleeding. Okay? So essentially we're doing, on a individual blood vessel level, we're putting a tourniquet on.
So they're more at risk of a catastrophic bleeding.
So it depends what the problem is. So someone who's got leukemia, for example, who doesn't produce any clotting factors, is more at risk of bleeding because they can't create a clot. And it might be that the hospital then gives them, so you can give someone an infusion with clotting factors. Okay? Or it might be that they're on a medicine that stops them from clotting, and we can give them medicines to reverse that. So it depends on what the patient is on, but that's where we need to do it, okay? So, as we said, arterial bleeding is a spurting bleeding, it's pulsatile, it's under high pressure. It can be really rapidly, it will usually be quite rapid, where it comes out quite quickly, and then as the blood pressure drops quite rapidly because the volume lost is quite quick. Veins, because they're large but they're not under such high pressure, there'll be more of a flowing, and they can still lose a lot of blood from veins quite quickly just because of the volume that's within the veins. Okay? Whereas capillaries tends to be quite slight and oozing type bleeding, almost like a trickle. Again, it depends if it's a small graze on someone's elbow has rubbed against the wall. Probably just put plaster on it, and most of us have had a graze, we put plaster on it, it hasn't really bled that much, and the plaster is more for psychological pain relief rather than actually treating it. But you can get people who can do quite significant amounts from graze, especially if it's a large graze. Okay? And certainly Usher, in his experience, has shown us pictures of patients that he's seen at major incidents where they've grazed a large part of their body, especially motorcyclists as they graze themselves on the tarmac, and they just trickle continuously out, and you have them on the spine board, and you don't see a lot of bleeding because it's coming out very slowly, but then you take them off and you discover that the entire bed is full of blood because it's trickled out very gradually as you've been looking after the patient. So you can get the whole range, okay? And it's about recognising that any of them can be severe. And how will we recognise how severe it is?
Blood pressure starts to drop.
Yeah.
It's the heart, the breathing starts becoming more difficult.
Yeah. So we'll go back to those signs that we spoke about at the different stages of shock. So the level 1 might not, up to 10% we might not notice it. 10 to 20% they'll have a slightly faster heartbeat. They'll have a slightly faster breathing rate. They'll appear a bit more anxious, but very subtle signs. Then as it progresses, that breathing rate will go up, the heart rate will go up, the blood pressure will start coming down as it progresses. So that's why it's so important to keep an eye on it, because it might be that it looks like a small graze that's not bleeding very much, but the stuff on the spine board, we're not keeping an eye on it all the time. It's gradually trickling out, and if we don't keep an eye on it, we might miss it as things deteriorate. Okay. How would we manage it? Pressure, absolutely. So what sort of pressure?
So it's, depends by the situation. So either can stuff that you can just something over your plastic.
Yeah.
Right?
Okay, yeah, you can use.
So basically what we want to do is to stop the bleeding and want to optimise whatever we have left in the system, right? So we'll keep the person sitting down or laying down, because standing up has the highest demand of blood pressure, isn't it? Because the head is furthest away from the floor, so we'll sit them down. We want to try and find out what type of bleeding it is, okay? And we'll put pressure either on the point where it's bleeding, or we'll try and pack it, as we've said, or we'll try and put a tourniquet on it. The important thing is to recognise that when someone is bleeding, that first blood clot that they will form is the best blood clot that they will ever form for that injury. Okay? So don't be tempted to put your finger to stop the bleeding in whichever way you stop the bleeding, and keep checking to see if it stopped bleeding. Because every time you take that pressure off, it disrupts that clot that's forming there. And when you disrupt that clot, all those clotting factors that have been used are gone. They won't. It's not the okay. Slow down. Took your finger off. Okay, not quite. Put your finger. You've not returned those clotting factors there. They've gone, and it's now going to start all over again. And the more times you do that, the less clotting factors the patient will be left with.
Yeah. So in this case, I just need to replace let's say my finger with the.
So if you're packing it, when you're packing it, as you're packing, you're not actually taking the pressure off. When you're packing something with the gauze and the hemostatic dressings, you're keeping the pressure as you're doing it. What you're doing is you're replacing the pressure from your finger with the gauze as you're putting it in. So the pressure is still there. You're not letting that clot come off. You're just replacing how you're putting the pressure. Okay? But it's about keeping that pressure there, and we don't take that pressure off once it's stopped. Okay? So we'll get the pressure on, keep it there, keep it all steady, and then once we've got control of it, we'll think about dressing it so we can get to minimise the risk of it getting infected, minimise the risk of getting further problems with it, and also so we can get it to somewhere where it can be managed further.
So if there are multiple wounds, you concentrate on one at a time?
It depends. You'll set them in order.
Yeah.
You'll deal with them as you can. Now you can only deal.
So you can't
pack lots of wounds because you need 2 hands for each wound. So if it's just you and the patient and they've got 2 large wounds, you're going to have to decide which one you're going to deal with first. Yes. If there's a number of people there and they've got a number of wounds, then each one can deal with one as it goes along. If it's one wound is a graze that isn't bleeding and one is a major wound, so you don't need to deal with a graze straight away, right? If it's lots of grazes, then you'll deal with them. So you need to decide what's the most important one right now, and make a plan of action how you're going to deal with it. Okay.
Also, if the patient's really attempted to put pressure on it, you don't know whether you're doing the first cut or not. Come in.
You do what you can.
Yeah. So you don't know whether it's the first cut anyway.
At some point you're replacing that with the bandage.
Hmm?
At some point you're replacing that with the bandage.
So the bandage is there once you've got control of the bleeding. Okay. So you can use the bandages because the bandages come with various devices in them to help you keep that pressure in place. But the bandage isn't there to replace your initial treatment. Okay? So your initial treatment is to stop the bleeding whichever way you do it. It might be that you stop the treatment by putting a bandage with a pressure dressing on it and use that to stop the bleeding. That's fine. Whatever you do, don't keep changing it. Yes? Okay. So, thinking about that, so we've managed catastrophic bleeding first because that's the most important thing. There's no point in having a lovely airway and air going in and out of the lungs if there's no blood to go around the circulation. And then we'll manage catastrophic bleeding first, and it could be catastrophic arterial bleeding, it could be catastrophic venous bleeding, it could be catastrophic capillary bleeding. It doesn't matter which one, but whichever one it is, we'll manage that primarily, and then we'll go on to manage the next problems. Okay, and there's various things that we can use. So, for example, the dressing that we've got in the middle. So it's a pressure dressing or an Israeli dressing. So it's a stretchy dressing with a bit of gauze in it. Is this open? Let me just check. Okay, so we've got various dressings here. So these dressings, basically, they're different examples of dressings that we've got, okay? So if we start with this dressing, so this is
with the clotting agent.
this is a clotting agent, absolutely. So it's Celox. So
What's
this
the
is a
name of it
brand
again?
called
Is
Celox.
like a nickname for it?
This is Celox. It's a brand, okay? So basically, this is, you've got a wound, you're going to pack this into the wound, and you're going to use this to replace that direct pressure that you're doing. So you're keeping the pressure there as you put it into the wound, okay? And it becomes very long.
Will he help with someone with like leukemia?
Hmm?
Will he help with someone with leukemia?
Yes, because clotting agents in it, so we'll help create the clot itself, okay?
That's for deep.
This is the news. That's it. I'll put the videos up. Okay.
Don't get arrested, yeah?
So that's a hemostatic.
Yeah, so it's a hemostatic gauze. Okay, so it's got clotting agents in it.
Yeah.
They're denatured, so you don't need to worry. So it's made from shellfish, but you don't need to worry about the person being allergic to shellfish because it's denatured. So it's not. It can't cause an allergic
So
reaction.
if we can, it'd be best to go in with the dressing as opposed to stop with your
No, the first thing you do is you use your hands and then you step up as you can, okay? You've then got pressure dressing, so this is an example, it's called an Israeli bandage. So you've got the gauze essentially there. Can I borrow your arm if that's all right? Yes, say there's a wound here, we'll put the dressing over there, this point there. Okay. Then you put this through that, and then you pull it backwards, and can you feel that pressure there?
Yes.
Yes? So it's putting pressure on it.
How strong do I need to, how does it care?
Yeah, you put it as tight as you can, and you keep wrapping it around as you go all the way around, and as you pull it
I
tighter.
can feel it tightening, yes.
I'm not doing it particularly tightly because I don't want to cause any pain, but you can feel that pressure on it as it goes around.
Yeah.
You keep wrapping it around until you get to the end, and it's got clips here that allow you to keep it in place. Okay, so this is one example of a pressure dressing. There's the ambulance dressing.
It's quite a small pressure area, right?
Yes, because
Just
you
that bit.
yes, that's just the bit that you want
What
the pressure.
what if the cut is that way?
So you want the pressure to be on the point that's bleeding. It doesn't matter how big the cut
So
is.
in this case, from what he said, with stuff in,
I will
and then
size.
So you might
Yeah,
need to stuff the pressure and then stuff it with gauze and then put this on. It doesn't matter. These are all okay, and they come in different sizes. So the ambulance dressing. So this is the equivalent of a size of a number 1. It goes all the way up to size 4. Okay, these are just examples of the dressings.
So this is basically doing the job of the tourniquet plus.
No, this is not doing the job of the tourniquet at all. This is doing the job of your direct pressure. This is doing this.
After packing,
You put this on and it keeps the pressure there. Yes. Or it might be if it's not a wound that needs packing, you might just put this on.
I see.
Okay. If it's a wound that isn't actively bleeding, you might just be able to put on a simple dressing.
Right.
You need to check the wounds that you've got.
And with all the pressure this is putting, it can be instead of a tourniquet, like.
So tourniquet is the next step up. Okay.
then again, it's not stopping.
No, but this is
It's
putting
before
pressure.
it's not on the wound, it's before the wound. Because we need
Yeah.
Yes. So
Cut the
tourniquet,
supply.
the tourniquet is cutting off the blood supply to that wound.
So before the.
Is this
I guess-
landscape and NHS have this one as well? Is it
Yes, it's called, no, this is from CST. It's called an Israeli bandage, but it's the same as a number 1 ambulance bandage. It's just a slightly different design, does the same thing. Okay, and they increase in size, and then you've got your blast bandages, which is these ones. This is the ambulance size 4, and this is where you've got a massive wound that you can't really put pressure on. Okay, and this comes slightly, so it's got Velcro on it, which means it doesn't unroll completely as you open it along. Okay. But it comes with a plastic sheath that you can use to cover abdominal contents, because the bowels, if they fall out of the back abdomen, they can dry out quite quickly. So you put plastic on them to keep them moist, and then it's got a large gauze that you can use to keep a large gauze pad that you can use to keep it all dressed up. Okay. And it's got these velcros, which means that it doesn't completely unroll as you go along. Or in theory, it doesn't completely unroll as you go along.
Pick up a little bit dirt on the floor.
Yeah. So as you can see, nice big square. Says on the other side of the wound. Yeah. It has a small pocket in it over here, at the top, which has this plastic sheet. This plastic sheet is just if you've got more internal content sticking out, you use it to cover it just so it doesn't dry out. Okay? Does that all make sense?
Yes.
And then
So if I see, for example, that basically the smoke is out, just
Yeah.
cover it with
you cover it with this. Well, you won't be able to push it back in because it's under pressure, so it won't stay in. Yeah, you cover it with plastic so that it doesn't dry out. You then put this bandage on, and you've got this that you can wrap it around, and you wrap it around not too tightly, but fairly firmly. Okay.
It's like explosives. It's basically.
Yeah, it's called a blast bandage. Okay. And then, if you've got a long bone that's bleeding and you haven't managed to control it, you then have the tourniquets that you can put above that.
But it can help only in those.
Well, you can't put it on the abdomen or the chest, and you
Yeah,
can't put it,
because
and
it's
if you put it on the neck, then there's no point. No, it's a reasonable question, but I'm saying
No, I'm saying that it's like a tourniquet. in
yeah,
general.
tourniquets is for long.
This is the only places that we can
Yes.
basically be close to.
So it's the only item where we don't place it directly on the wounds.
Yes. Tourniquet is the only one you don't place directly on the wound. Can I borrow your arm again? I'm sorry, you're going. Okay. It comes with a Velcro. You put it on. You want to put it fairly firmly. Okay. Wrap the Velcro around, and then you need to twist the locking handle until it stops bleeding. Now I'm not going to do it because it is quite painful. And you can feel I've done what, quarter of a turn.
Yeah,
And
that's it, yeah,
you start, but you're going to turn it. It is quite painful. Okay, and then you lock it there. Tourniquets are really time critical. So once you put a tourniquet on someone, they are time critical to hospital. Because you've only got a couple of hours before it has to come off.
So you time it as well.
So you'll write the time on it, you'll document all of that, and you need
In
to,
every tourniquet I have this,
all these tourniquets come with this, yeah.
like any sort of tourniquet we have, but I remember you used to write in the...
Yeah, so you write on the forehead T and something,
And then it
As-
sweat and...
yes, as long as it's very clear that there's a tourniquet on and so it's time critical, that's fine, but it's a time critical thing because if you don't take it off soon enough, then the limb is irretrievable.
The big one is for the abdomen.
Yes, so it's a blast bandage. So it doesn't have to be for that. If someone has a large amputation of the arm or leg, you might put it over the end and use that to wrap it around.
No, I understand. I'm just wondering if all the blood that's coming out, I'm putting the blast bandage, and now it's
Yeah.
just congregating inside the stomach.
So
Is that-
yes, but so it might be, but you won't. But you're doing the best you can for the patient in the situation. You're going to be taking them to hospital as urgently as you can. Okay.
I see. So it's still is okay.
It's yeah. Okay.
If it's still bleeding after you apply the dressings, does that mean you haven't applied the tourniquet correctly?
Yes.
Yeah.
Okay. Any questions about any of that? Now I am aware that it's 12 o'clock now, so I'm going to take a small break now for a few minutes. Is that all right?